on practice guidelines, and and I know that we're running behind, so I'll try and be as concise as possible here. So I'm going to go briefly through clinical practice guidelines, purpose, and their role in high value care. I'm going to talk a little bit about the Cancer Care Ontario program in evidence-based care, which is a program run by the Provincial Cancer Agency in Ontario to develop rigorous evidence-based guidelines. Sheila McNair is the managing director, and she was kind enough to loan me some slides for this. And I think what it describes is we describe some best practices for developing rigorous guidelines and some of the advantages and disadvantages of that process. Talk about some barriers and facilitators to clinical practice guideline adherence. Talk about just a recent study on concordance of resource stratified guidelines, and then bring it back to what we've heard about guidelines in India. So this is from a recent paper. Treatment guidelines provide clinicians with a framework for recommendations for evidence-based therapies. And I think that this is one of the keys. We talked earlier this morning about the importance of clinical research in improving outcomes for patients. And one of the final steps is the consumption and implementation of that. And busy clinicians may not have the time to go through all of the latest research studies, critically appraise all of the literature. And many clinicians will rely on clinical practice guideline organizations like NCCN, ESMO, ASCO, Cancer Care Ontario to review the data critically and to synthesize that. So guidelines can improve the quality of clinical decision making, facilitate care delivery, optimize patient outcomes, and may also inform government spending priorities. And we've heard a bit about that. We'll talk about that a little bit more in a bit. So the program at evidence-based care, this is a satellite map of Ontario, nestled right on the 5 Great Lakes. Since 1993, the program in evidence-based care has been developing evidence-based guideline, enhancing a culture and capacity to use and appreciate the value and role of evidence in Ontario and beyond, and to apply formal, explicit, and rigorous methods of evidence synthesis. And I think that it really is quite a robust process. These guidance documents support the evolution and sustainability of an evidence-informed culture for care delivery. Since 1993, they've produced more than 350 guidance, evidence summaries, and other reports. And from those 350 guidelines, had more than 239 publications. So it's a very productive group. I've been fortunate to be involved for more than 20 years with this organization, and for the last 5 years, have co-chaired their GI disease site group. So this requires investment, and I think Cancer Care Ontario, as a provincial cancer agency, has recognized this and invested in a significant staff to invest in this. But this is also one of the drawbacks in terms of the amount of investment and the time it takes. So I think that this needs to be considered as well. So for each guidance project, there are sponsors. Those are generally disease site groups who want to bring forth a project. The program in evidence-based care provides the support to produce the guidelines. This is supported by oncologists from across Ontario who provide content expertise and try and make these as clinically relevant as possible. And then a really important part is that patients and families are involved to provide perspective and reality check, and to provide contribute to the value decisions that have to be made. So I'll go through briefly the guideline development cycle. A topic is identified. There's project planning. The document development is really quite extensive. With the methodologists go through a formal and systematic evidence review. And most of these guidelines are also accompanied by systematic reviews and meta-analyses that can be published, but also with concise recommendations. And then I think the other key part is, in addition to this incredible incredibly rigorous evidence review and synthesis is once the final document is created, both internal review by the methodology panel and external review by content experts around the world, international experts. And then it's finally reported and published on the both on the website for easy access and in peer-reviewed publication in peer-reviewed journals. So I think that the key things is that there's a formal, the key strengths are that it has a formal and explicit methodology. We ensure that the appropriate content experts are at the table. They have a great team of methodologic expertise and resources. And then the content experts to interpret the evidence and judge the applicability in specific clinical situations. Again, provide clinical context to the trade-offs and balances between benefits and harms, and report on these transparently and explicitly. One of the major issues is that although there's substantial investment, that has been scaled back over time. And whereas the disease site groups used to be able to say, we just want to, we're given great liberty in choosing the topics they produce guidelines on. Now it goes through a central review. And I think this is good because it actually allows it to align it with CCO, Cancer Care Ontario clinical pathways and where there are gaps. You know, it looks at important things like the prevalence of a condition, the burdens of the illness, the relevance to practice in Ontario and elsewhere. And whether there's a sense that there's a variation in practice, either from the sense of the clinicians or from research, outcomes research that's demonstrated that, and then the likelihood of changing practice. And another key thing is there a chance for quality improvement within the Ontario Cancer Plan, which is a iterative process to ensure high quality care in Ontario. So I'm just going to show, this is one of our most recent reviews. It was just published. I was the senior author on this, and this was on systemic therapy for advanced gastric and gastroesophageal carcinoma. I think Pramesh, in your talk, this document's over 100 pages long. Nobody wants to use that. However, it is a good resource, rigorous and synthesis. Now, that 100-page document, though, we summarize into 2 pages for people, and we realize most people are going to focus on that. And here's an example. So this comes down to, and we summarize it quite carefully. The objectives, the target population, and you can see that in terms of our objectives, in keeping with you know, a lot of the talks today, this is to provide guidance on optimal systemic therapies for the treatment of advanced gastric and gastroesophageal carcinoma. Optimal systemic therapies were defined as those that provided improved overall survival and improved quality of life. So right from the start, we're looking for high value care with those parameters. And then just an example of a recommendation, medical oncologists should prescribe either fluoropyrimidine oxaliplatin doublet or fluoropyrimidine irinotecan doublet in the first line. We also comment on the use of triplet regimens. And when we were in GI clinic yesterday, it was interesting to see that triplet regimens were being used here. We don't tend to use them much in Ontario or Canada, but we're happy to hear that there's actually a randomized trial going on here. And it'll be interesting to see how that balances with risks and toxicities. At any rate, the key thing is that we distill this down. We want this to be useful for clinicians and distill it down to a short, concise document that gives them information that they can use. So some of the limitations, we do put a lot of work into this. It's a very rigorous process. We've done very little to look at the actual impact it has on care. The best way of having an impact on care, and I think we just heard in your talk, Pramesh, in the last talk, that linking guidelines to funding is the best way of driving of linking that high quality evidence to use. Now, the other thing is we don't comment on value explicitly, but we have a parallel national evidence-based drug funding program to evaluate drug value. So prior to that national program for assessing drug value, these guidelines were tied to funding and had a big impact on policy. Now we have a parallel program that uses evidence-based, but also ties it to value. I'm going to just go through this quickly. There has not been a lot of research on how guidelines actually impact care. This is just one study that was a systematic review of 15 studies, qualitative and quantitative, that looked at perceived barriers and facilitators to cancer treatment, clinical practice, guideline adherence. And the four themes, obviously accessibility and ease of use. So having a website, having these easily accessible is absolutely essential. Endorsement and dissemination of guidelines and adequate access to treatment facilities and resources. Awareness of the guidelines and belief in their relevance, and belief that these guidelines support decision-making, improve patient care, and reduce clinical variation. Some of the things that identified which were negative clinician attitudes and barriers were concern over content and especially the currency. So we do update our guidelines. We have a formal process for updating them on a regular basis. Concern about the evidence underpinning the guidelines, clinical uncertainty and negative perceptions of guidelines, and some organizational factors. So this is just, I wanted to highlight this because we've also been talking about resource stratified guidelines today. And this is a paper that was just recently published looking at resource stratified guidelines for cancer from 4 different organizations. Brooke Wilson is our newest faculty member at Queen's Oncology, medical oncologist, and our newest member of our global oncology program. So we've heard about resource stratified guidelines, but they're developed to provide a hierarchy of treatment recommendations depending on resource availability, include 4 levels: basic, core, enhanced, and maximal. Basic resources are considered minimal essential diagnostic and treatment options that should be available in any cancer system, like the WHO listing of essential medicines, for example. Maximal services include therapies that may offer benefit but are not cost effective in low resource settings. And so this study looked at 69 resource stratified guidelines covering 15 solid tumors produced by 4 organizations: ASCO, ESMO, NCCN, and the Breast Health Global Initiative. And despite using common resource level definitions, there was quite a variability in recommendations between the organizations. Chemotherapy recommendations was the concordance levels for chemotherapy was poor in at the basic level, fair in core, and excellent in the enhanced and maximal settings. Endocrine therapy were good in the basic and excellent in core and enhanced and maximal settings. And targeted therapy recommendations were moderate to excellent across all resource levels. The way this group interpreted this was that the greatest discordance was in treatments with intermediate costs, like chemotherapy, where there can be significant variability in pricing between countries. And consequently, the value of these treatments is likely to vary considerably between the settings. So I'm just going to come back now to the National Cancer Grid and tie this back in. So I think that a couple of things. One is, Pramesh, you commented on Dr. Sengar's recent work that is looking at how these guidelines are developed, and they use an ADAPT strategy, adapting guidelines from other using the ADAPT tool, aptly named. And I think that there are a lot of good guidelines, and I think that the Cancer Care Ontario guidelines could be one of the source documents for this. I think that tying these to having the essential and optional level and tying it to funding is absolutely key in terms of driving high value care. And we saw how that impacted funding through the talk that we just had. Thank you very much.